unfortunately, a lot of these patients, they have what we call a leaky gut, and the immune system that lives in your intestine can be triggered. And these patients develop allergy very easily. So you do see more of a milk protein allergy sometimes in these patients. And so at that point, you may have symptoms of diarrhea, you may have symptoms of blood in the stool, like you would any other child with milk protein allergy. And at that point, you have to decide, maybe the mom can restrict and try it. And sometimes you have to move on to formula.
So thank you once more for joining us to another podcast. We have here Dr. Jennifer Garcia. It's a pleasure having you here today. She's the head of program directors of intestinal rehabilitation, intestinal failure transplantation, pediatrics and adults at the University of Miami, position that you've been holding now for how many years?
For 15 years.
15 years, yeah. The time's fly. And we wouldn't say new baby. Congratulations on your son.
Thank you
3
so
years
much.
old.
My biggest challenge so far.
And thanks for sharing sometimes with us and hopefully some knowledge as well.
No, absolutely.
Well, we're going to start head on.
Thanks for having me. It's a pleasure to be here, especially with one of the few that actually witnessed me falling in love with intestinal failure.
It's been a great opportunity to see that as well. And we're going to talk about your progress and what you're doing right now. So so tell us a little bit about your center. So what you're doing in pediatrics and adults in UM, and how fast you are growing.
Yeah, no, absolutely. I think, we're very blessed. We're one of the only centers in the United States, I would say, not even South Florida, that has both rehabilitation and transplant, and actually motility as well. So we're able to offer like the whole gamut of care for these patients that are so complex. One of the key things that has come out in the last 20 years is the importance of multidisciplinary care. So the experience that we have at UM Jackson is very hard to compete with in all aspects.
So it's a busy clinics in terms of dividing these words in rehab and transplantation.
Yeah. So we have two different programs. We try to divide the staff also. I think actually I'm the only one that takes part of both, because really the gold standard is rehabilitation. If you can avoid transplant, obviously that's the way we want to go. So we have a truly independent team, not just myself, but the surgeons are different for both rehab and for transplant. We have a true multidisciplinary team, including a social worker, a dietitian, a nurse, and a nurse specialist, and they're all separate for both teams. So I think that's one of the keys that makes us different.
Stephanie Hernandez was a previous guest, and we spoke a little bit about liver transplantation, and we spoke a little bit about biliary atresia. So in pediatrics, staffing one physicians at your center, because you're a hepatologist too.
Correct.
That she's helping the intestinal rehab, intestinal transplantation patients liver-wise, or how do you divide that?
So she does inpatient. So gastroenterology team as well as the transplant team both take part. Whenever we have a patient come to us for the first time, they're usually under the intestinal transplant team, which is Tiffany's part of, and Dr. Hochberg as well, and then as well as our transplant surgeons. But really, once a patient goes home and they need to get readmitted for any reason, then they'll go on to the GI service, which has many, new and old attendings, as you know, that are taking part of our team. Yeah.
So mass, but days pass. So I remember that new consultations from out of state, they would come and stay for a few days at the hospitals for evaluations and so on.
Yeah, so we get, for intestinal rehab, we get patients from throughout the state. And as you mentioned, some even from outside the state and even outside the United States. But yeah, we try to admit them for about 5 days. And then we help a lot with discharge planning. As you know, when you and I first started doing this, or at least when I started doing this, it was really based on hospital care. Patients would be in the hospital for 2-3 years until they came off parenteral nutrition, which we could talk about, or they went on to transplant, or unfortunately, some of the patients died. Now the push is really to do the care at home. So of course we can provide home nursing, we can provide, something called PPEC, which is pediatric prescribed care, which is special day cares for patients with medical conditions, but nobody's going to take care of their child better than the parent. So we really try to bring them in to do any testing that needs to be done to get to know the patient, their anatomy, their status, where they are in their rehab journey, and then set them up for success at home with whatever services they may need.
Because we were discussing before this podcast the importance of, not only the outcomes during surgery for adaptations or any type of surgeries in these patients, but also how to develop a proper team where communications among the team that takes care of the patient. So I think, that probably has been one of the success at your center too. Had you been able to control or establish that team that takes care of your patients as well. Do you have PPECs that they focus on intestinal rehab parts of these patients too?
So
That's
they
what you're trying to say?
because they have our prior patients. So they know our protocols. There's many PPECs, let's say, in South Florida, and we know which ones have the experience in taking care of our patients previously, which ones, really followed the orders, were able to tell us and participate with the adaptation process. Like if, we're trying to go up on feeds and the child is not tolerating, they'll call us, they'll tell us. So it's kind of like another eyes and ears if the parent is not there during the day and these nurses are there. So we have picked a few throughout the South Florida that work better with us. And of course, it's always up to the parent. They go, they tour, they pick or not. But yeah, there's a few that work better with us. Also, not just outpatient, that PPEC, but if the patient is at home, my nurse practitioner has been with me for 10 years. My social worker probably has been with us for 8 years. And between them two and our dietitian as well, they know a lot of the everyday care of the patient, the tricks of the trade that they can teach the families and try to avoid the ER visits or even the hospitalization.
So how many nurse practitioners you have in your team, social workers or dietitians?
Yeah, so we have one in each of the services. So we have a nurse practitioner for intestinal rehab and one for intestinal transplant outpatient. Inpatient, we have 4. But outpatient, we have one for each. We have one social work for each, one dietitian for each. And actually, we have 2 dietitians because we have one on the rehab side that does enteral nutrition and the other one that does TPN. And they all know each other's work. So if one's on vacation, then the other ones can cover. But from a day-to-day basis, we try to have the teams separate.
And I guess you have protocols in terms of how often you're going to, once they leave the UM or Miami, like how often they're going to follow labs and meetings with you on the phones and so on.
Yep. So in the beginning, it's intense. We see the patients very frequently, once a week. They'll have labs once a week. Very rarely we'll have one that needs labs twice a week, but very rarely. And then as they do well, then they'll start to space out the labs every other week. We have patients that have been on TPN and have chosen to stay on TPN for a longer period of time, and they're do labs once a month, and they're very stable. Same thing, I think, one of the beautiful things, only good things about COVID is that we all learned how to do telehealth. So because we take care of patients that live far from the center, we often do use telehealth with the agreement that they have somebody local. So either the pediatrician or another gastroenterologist that may not be as specialized as us, but that's willing to see the patient and help us, understand how they're doing physically, so like that they don't have to travel all the way to Miami. One of the other beautiful things too is something called Angel Flight, which we use, which is they're volunteer pilots that will fly the patient down to Miami and then fly them back after the appointment. So a lot of our patients that are, farther than Orlando, they rather just do that, and they're on the plane for 50 minutes and then they go back at the end of the day. So it's really nice.
Well, it's even better, so they don't have to stay in Miami and
They
pay
don't
for
have
the
to
high
stay.
costs of staying in hotels and things
Correct.
like that, or stay in the hospital.
Correct. And, we do use the Ronald McDonald House. We have one on campus, as you know. And so if the patient, there's some people that don't like flying. They rather come by car. A lot of times the insurance will pay for either the transportation or they'll reimburse the family. And if they want to come and stay the night, if they have another test to do or something, then they can stay at the Ronald McDonald House and then they'll go back the next day.
Yeah, the importance of us talking about this is it's not only for families and patients, it's how in medicine overall you have to have well-organized teams or a group of physicians or staff that help us on the care of these patients. Otherwise, you're going to lose controls of what you're doing.
Correct. And I think, because of the transplant side, we were used to being one of the only centers in the US. So we got really good at working with other teams. And we've applied that now to the smaller scale in Florida. So I very commonly work with physicians in Orlando, in Tampa, in Gainesville, wherever, and as either a second opinion or as a primary with another GI taking care of them, depending on what the family and the physician feels comfortable with. We're very much used to working in teams because that's the only way. Nowadays, it's important to keep the patient closer to home. These patients are living on TPN longer. You can't put your life on hold for 3, 4, 5 years. I mean, you can, but it's better if you're able to integrate the other siblings. People have to go to work, whatever it is, and you're able to do it if you have good communication with the local team.
Yeah, quality of life is very important, in this case. Now, in terms of concepts, I think it was late 90s, Oliver Goulet in France, he came out with the changing the terms from short bowel syndrome to intestinal failure, and then adaptations and the medical management of these patients during adaptation. Now, does the concept still the same for intestinal failure? What does it mean when you see a patient and then you say this patient has intestinal failure?
Yeah, so Dr. Goulet, one of my mentors, just like you, right? So it's an umbrella term, intestinal failure. Basically, it's just a definition. That means that for whatever reason, you're not able to use your gut to absorb enough nutrients, to absorb enough fluid, to absorb enough electrolytes to keep you alive. And not only to keep you alive as a child, but to help you develop normally and grow normally, which I think is one of the most important keys of intestinal failure in children. These kids, most of them, all they have wrong with them is their intestine. The rest of them should be able to function normally most of the time. So now there's different conditions that can lead to intestinal failure. And the definition of intestinal failure is just you needing nutrition through a vein, parenteral nutrition it's called, for 60 days. What got you to intestinal failure could differ. Most commonly is short bowel syndrome. Most commonly there, it's kids that are born with a condition or they develop a condition very close to after they're born that leads them to have part of their intestine taken out by a surgeon. Sometimes as they get older, there's other conditions like Crohn's disease that's not well managed. I've even seen accidents, that have led to a patient, having a trauma to their abdomen and they've lost their intestine. So whatever the reason is, they have a short bowel. That's the most common. About 65-70% of the patients will have that. The second category that's also common, 20-25%, is something called dysmotility, which again, it's a broad category. For some reason, you're either born or you develop a problem with the muscles or the nerves or the cells themselves of your bowel where it doesn't move properly. And then there's the other rarer occasions that are much more common in adults, like, you have an obstruction for some reason and you lose your bowel, or you have a fistula that develops from Crohn's, things like that. But the most common are the short bowel syndrome and the dysmotility, and most of those start in childhood.
Are you still seeing this group of congenital enteropathies, like a microvilli? We used to have a patient from the Middle East in the past, with consanguinity and microvillus inclusion.
Right.
You're still seeing those?
We are. It's much more rare. I would say about 5% of the patients, as you mentioned, most of them are because of consanguinity, genetic reasons. Some of them also, can be rehabbed partially, and patients, stay on TPN long term until if and when they're ready for transplant. But yeah, we do see them. They're just much less common than short bowel. I think, as medicine has advanced and neonatology's, care has advanced, then more and more patients that in the past, would unfortunately die now can be saved. And they're given an opportunity to live on TPN until if and when you're able to get them off or they go forward to transplant, which is probably something that 20 years ago we didn't see as much. A lot of the patients, I think, at that point, were told that there was no hope for their child and the patient would pass without much intervention because we didn't have what we have today.
So when these patients, let's say, for example, they already been diagnosed with this intestinal failure, and they are going to require to survive hydration, nutrition, parenteral nutrition for more than 60 days, as you say. Mm-hmm. Then you start, as a physician, you do straight parenteral nutrition, combinations of feedings. The feedings you're going to do in combinations of TPN. So how do you manage that combinations of enteral nutrition with parental nutrition?
Yeah, so the goal should always be to try to take a patient off parenteral nutrition. Again, nowadays we're able to keep, patients very stable on TPN for many, many years, but that as a physician, that's your goal. Take them off TPN because you never know when they can develop a complication. So combination, this is something that we do in collaboration with the family. Of course, there's times where you have a preference as a physician and you, of course, tell them what your choice is. But again, you have to work and see what people really prefer for their child. I think the vast majority of our patients, we try by mouth first. And, what we call bolus feeds, just like any other baby eats. You give them a bottle and see how much they can take, they can tolerate. And then, you go from there. I think the vast majority do best, and you're able to advance more in combination. So you're feeding them by mouth during the day so they can develop like a normal kid. They don't lose that ability to eventually eat a regular diet, which is the goal. And then at night, we tend to do continuous feeds because at that time, usually through a G-tube, at that time, the baby needs to rest, the family needs to rest, and, you're able to advance a little bit faster. I think in the past, we used to do more continuous feeds all the time. And in the last probably 10 years, we've come to realize that if you're feeding too much that the child may not be able to tolerate, you actually can have secondary effects from that and more bacteria overgrowth, et cetera, et cetera. So we've gone away from that unless it's absolutely necessary. Very rarely do we have only TPN patients. I think the only TPN patients are now more the dysmotility patients that just don't tolerate even a sip of water without becoming very nauseous or, vomiting and having trouble. The vast majority of patients, you want to give them something by mouth or if not a tube to not only get the development going, but also to keep the liver happy.
Yeah. So you're trying to prevent food aversions on these patients by giving oral intakes as much as you can.
As much as possible.
It's more natural.
It's more natural. You get,
I think developing wise for kids is also better.
Development and also giving a break to the feeds, preventing some bacterial overgrowth because you're not what Dr. Goulet labeled gut overload syndrome. When we're controlling how much you're going up on the feeds just by going up with the continuous 1 cc a day, let's say, you're not giving the body a chance to adapt. You're letting the bacteria take over at some point. But that does take longer. As I mentioned, sometimes I really believe some by mouth is very important, but the continuous, is also key to advancing faster.
Yeah.
The only study that's ever been done in humans saying which one works better, it's the combination. But sometimes it's hard to convince parents to, they already have a central line for the TPN and now you're asking for a G-tube in their stomach and these parents want some control. And some of them say, I'd rather take longer and do everything by mouth until you get stuck, and then eventually they'll give in.
Actually, it's a good point. I was thinking when you were talking about giving the patient a chance on bolus feedings. I'm going to jump a little bit about the length of the small intestines and what you say. So babies are birth that you have average close to 10 feet of small intestine, which is it's close to 300 centimeters of small intestine, or 3 meters. You are seeing babies, we're seeing babies with 40, 50 centimeters, or not even a foot of one foot of small intestine left after they go through all this process of surgery and so on. It's my understanding that your endogenous, we're going to talk about this a little bit, but it's my understanding that endogenous GLP-2, which we're going to mention this about that as part of the treatment, new treatment, it goes out during bolus feedings. I don't know the difference of enteral continuous feeding, but definitely the use of parental nutrition blunt your GLP-2 response.
Correct.
Meaning that all these babies are mostly dependent on parental nutrition without too much of enteral nutrition. Maybe not even some bolus intakes by mouth. Maybe that we are blunting growth of the small intestine the first year of life.
Yeah.
Which is to max out growth of the small intestine. Now, in terms of length, can you remind us how do we see prognosis? Based on what is left after they going through this massive amount of bowel resection?
Yeah, and even that has changed a lot in the last 10, 20 years. I think when you and I were working together, the key was more than 40 centimeters. If a baby had more than 40 centimeters and they had a colon and they had an ileocecal valve, those were like the three things that you looked at and say this patient's going to do well. With now the new therapies we have, how much we've learned, just with, taking care of more and more and more patients, we've dropped that number to the point that I don't ever tell a patient you are 100% going to need a transplant to come off TPN, or you're never going to need a transplant, because every patient is different, right? You should never say never and always. So, we all have GIs that do intestinal failure. We all have that one patient that had 10 centimeters that did well, that had 5 centimeters that did well. Of course, it's one patient out of 100, but you will have it, and you don't know when your next one's going to be. So I think also very important is how old is that baby? Because if you, like you mentioned, if you're full term and you are born right now, you have 300 centimeters of small bowel. But if you're born premature, right, and they lose 50% of their bowel, that baby has not done growing, right? That baby's still, they're preterm. For the next 12 weeks, they're still developing, and they actually have more of a potential of their bowel growing than if you have a full term that loses half of their intestine. Right, so that's one of the only areas where being a preterm is actually a little bit better than being a full term, right? So we always now talk about percentage of expected length. So not just you have 50 centimeters, but you have 50 centimeters, and how much is that in contribution to your age? Because as I mentioned, I also take care of adults. If you're one of you or me, right now, unfortunately, and we're left with 50 centimeters in a kid, that's amazing. In an adult, you're probably going to end up needing a transplant to come off TPN. So it's all relative to your age and what you're supposed to have.
So meaning that the science now, it has evolved so much that even what it may be like this, what we call ultra short segment small bowel, which is probably less than 20 centimeters, so those patients can have a good chance to adapt without the need of a transplantation down the road.
You should always try. And we actually just recently had a consortium of experts throughout the United States and the world, actually worldwide, surgical and GI, adult and pediatrics. Adults, we had a lot easier of a chance to say, okay, this patient probably will need a transplant. In pediatrics, too much discussion. We couldn't come up with a consensus because we all had that one patient that did well. I think what's more important is knowing that, you're going to continue to try to take them off TPN. And if you ever get to the point that you're plateaued, that you can't advance anymore, then how do you help that patient? What new therapeutic do you use to really find out whether they've plateaued or whether you need to start talking about transplant, if that's an option for the family? And also throughout that process, not just focusing on the feeding, but making sure that you're paying attention to what potentially can happen with TPN, so that you don't have any complications, so you have more time long term.
Now, in terms of the feedings of these patients, so the first 3-4 months of life is going to be a formula, they are formula. So how adamant are you on these infants early on to continuous, for the family to continuous breast milk versus formula? How do you do that?
Yeah, that's a great question. I mean, we definitely prefer breast milk if at all possible. Whenever we can, breast milk, breast milk, breast milk. Now, because these patients have a short gut, they've had surgery, they have inflammation. Unfortunately, a lot of these patients, they have what we call a leaky gut, and the immune system that lives in your intestine can be triggered. And these patients develop allergy very easily. So you do see more of a milk protein allergy sometimes in these patients. And so at that point, you may have symptoms of diarrhea, you may have symptoms of blood in the stool, like you would any other child with milk protein allergy. And at that point, you have to decide, maybe the mom can restrict and try it. And sometimes you have to move on to formula. And sometimes they run out, and of course, we have different formulas that we use.
And then advancing to oral intake, puree, are you adamant to that transition too, for milestones and nutrition-wise too?
Yeah, we absolutely encourage, oral, solids, usually at 6 months. We won't start it before then. It definitely helps the babies that are, vomiters to keep things down. It definitely helps, form the stools. There's actually a good study about the use of green beans, to form the stools. So we absolutely do like to start feeds for developmentally them to stay on track with good communication. That's why it's so important to have a good team, because if you're starting something, you want to know if a symptom, starts as well. So like that, you can change things for the better of the patient.
So, my guess is with your team also you're looking at nutritional parameters of these patients, aside their weight gain, growth, and vitamin levels. So how are you teasing that out?
Yeah. No, I think that's a great question. It's one of my pet peeves. I think shortcuts should be on the growth chart. I think sometimes people are so desperate to get them off parenteral nutrition that they'll start decreasing the parenteral nutrition, and they'll allow for the child that's supposed to be, say, on the 25th percentile to be on the 0 percentile as long as they're on the growth curve at 0 percentile. I think it's sometimes unrealistic to think that they're going to be genetically where they're supposed to. Like, I have families that are on the 90th percentile, and okay, this kid's shortcut, maybe he doesn't need to be on the 90th, but he should be on the growth, on the growth chart, because that tells you how the baby is doing also developmentally from the brain point of view, and going on forward, right? So we definitely measure not just weight and length and weight for length, but, mid-arm circumference, very important. And then vitamins, as you mentioned, not just typical, iron, do they have iron deficiency, or, the vitamins, but also trace elements. And so we have a schedule, and, we'll always at 1 month start checking different things. And then as the baby goes on TPN, we'll check the frequency different depending on the element. And also when they come off TPN, because a lot of times we think the baby's doing well because they're growing, but it's actually more important even to check them after TPN. When they're on TPN, they're getting their, most of their needs, and they, if anything, become toxic. And that's why you're checking it to prevent a toxicity. But when they come off, that's the most important thing, because a child can fake you out and they look good, but they're missing the nutrients that will lead for them later maybe to have a learning disability or to develop properly, right? So it's I always say it's a lifelong disease. I don't follow you only until you come off TPN. Yeah, the frequency may change. You may go from every month to every 3 months to every 6 months, and there's patients that we only see once a year. But you need to be seen just like you would be seen for asthma or for diabetes or Crohn's or anything else.
So in these patients, how often during the adaptations that they have some reflux component of this part, how often would you be using either a proton pump inhibitor or an H2 blockers, or one versus the other?
Yeah, that's a great question. So, you mentioned adaptation. We should talk about that. So adaptation is your body's own ability to heal itself and, in theory, make itself longer. So, instead of making itself longer, sometimes it makes itself wider, which we take advantage of later on. But it's just the body trying to adapt to its new short state, right? And parts of the intestine can take on the function of other parts of the intestine that were taken away, right? So that's important to understand the process of adaptation. In terms of, I forgot your question, PPIs, so vomiting. So I think one of the things that we've changed, maybe even in the last 5 years, is that we tend to intervene a little bit more than we used to. So vomiting in a patient like this could be that they're not tolerating their formula. It could be that they have reflux. It could be that they have an allergy. It could be that they have an ulcer, a stress ulcer. So although we don't scope right away, I've noticed that when you're doing your therapies, if the baby's not responding the way that you think they should be responding based on history, sometimes it's important to scope them. Sometimes it's important to do pH probes. Sometimes it's important to do gastric emptying. So to try to get to the reason why they're vomiting. Why? Because every medicine can have a side effect. So as I mentioned earlier, one of the problems that we see a lot in short bowel is what we call bacterial overgrowth. So now the bacteria that's supposed to, for the most part, stay in your colon, if you lose the division between your small bowel and your large bowel, which most of these kids commonly do lose, called the ileocecal valve, that bacteria can get into the small bowel and overgrow, right? Also, even if you have the ileocecal valve, in the process of adaptation, the bowel sometimes can make itself thicker. And because it's thicker, it can hold more bacteria. And as I mentioned, especially when you're on continuous feeds, when you're constantly feeding the bowel and the bowel is just not ready to absorb it, who absorbs it? The bacteria, and they overgrow. So one of the things people forget is that the acid in your stomach is supposed to be there for a reason. It's there to protect you against bacteria. And one of the common things that us as GI we do is, the baby's vomiting, he must have reflux. Let's give him a medicine to block the acid. guess who gets very happy? Maybe the baby, maybe you solve their symptoms, but the bacteria get super happy because now you have no acid to protect you against bacteria. And actually, sometimes the vomiting gets worse because a bacterial overgrowth can present with vomiting. So we tend to, if we think reflux based on history, we'll tend to do H2 blockers, which are weaker, right? We, once in a while, again, with a good family, that's why it's so important, the communication, because you can gather from a history, whether it's reflux or there's low, gastric emptying. Sometimes we will use a PPI once a day. If you're thinking that baby needs twice a day, which a lot of babies do with regular reflux, at that point we'll intervene and we'll either, like I mentioned, pH probe, or we'll do an endoscopy and really try to figure out why they're vomiting. And I've been surprised. Sometimes
it makes a lot of sense. So trying to figure out exactly what you're dealing with rather than just using empiric antacid, which it can aggravate the overgrowth and actually down the road the symptoms of the patient too.
Yeah, and these babies are very challenging. Like, we have a lot of babies that are taken care of by very good gastroenterologists, and they come to us and we fix them. Or they say, oh, you fix, I've been with so-and-so for so long and you fix them. Well, so-and-so probably also sees inflammatory bowel disease, reflux, maybe not liver disease, but all sorts of GI disorders, and they're not seeing short bowel after short bowel after short bowel. The more you do, the more you get a grasp for, oh no, this vomit is like this and this vomit is like that in a shortcut, right? So I think the volume and the experience that the center has is very important.
Now, this is the way that I practice. I wanted to get your feeling about this and how you are doing it. So you're suspecting now overgrowth, which is your own microbiome that is acting out, and it's either creating hyperfermentations with more diarrhea or throwing out distensions or lack of, or not you being able to advance this enteral nutrition. Usually I'm a big advocate to use metronidazole low dose on my patients, and sometimes I use it 2 months at a time. But there is this, my point of view, I think there is this debate of using cycling antibiotics or every 2 weeks antibiotics. I don't do it like that. So how do you do it? How do you manage overgrowth in your
Yeah,
symptoms?
I mean, that's probably the hottest topic right now in intestinal failure because it's so hard to diagnose, right? Because it will present with vomiting, diarrhea, which anything else can present with vomiting and diarrhea. So yeah, I agree that metronidazole is probably the most common that you would use blind, right? I tend not to move to other antibiotics, which commonly we use things like Bactrim, gentamicin that you can, instead of giving IV, you can use in the gut and it's not absorbed, which are probably the most two common, rifaximin, which is very hard to get. We tend not to move to those antibiotics unless we have other evidence of bacterial overgrowth. What is other evidence? I think one of the most common things, if you have a good parent taking care of the child, line infections. If the baby is ending up with a gram-negative infection like E. coli, Klebsiella, and you have a good family, for the most part, that is what we call translocation. That bacteria that sits in the intestine and overgrowth, and again, the leaky gut, it gets into the bloodstream and it infects the line, right? Very hard for me to believe that a parent who's good, the only other way they will get a line infection is if they take the line and they, dip it in poop. Yeah. I really don't think they're doing that, right? So I think when a baby starts getting a lot of gram-negative infections, they tell you that kid probably has overgrowth. And in that setting, you're getting the sensitivities, right? Like, they'll tell you what the bacteria is sensitive to. Yes, when they're treating the line infection, you give them antibiotics by the line, but then now you can see what antibiotic by mouth I could use to prevent these episodes. That's usually when I'll start doing cyclic antibiotics. The other way that we usually diagnose it is if we're doing an endoscopy for example, reflux, allergy, anything of what I mentioned, we'll do cultures in the duodenum, right? And they're not perfect, but if you find that one bacteria overgrows more than another to a significant amount, okay, maybe that's evidence that that patient has bacterial overgrowth and that you should use cyclic antibiotics. But I agree with you completely. Many a times we get consulted from, say, a NICU saying, oh, can I have your protocol about antibiotics? And should we put them on Flagyl every month or, Bactrim every month? And every baby is different. There's some things you can protocolize in this patient population, but there's major things that you should not. You have to treat each baby as an individual.
Will your patients, will you have to use often like an antimotility agent, like
Yeah, definitely. And again, in the beginning, you tend to go blindly, right? So if you have a baby that has diarrhea and you think that it's not that they're not tolerating the formula, they just need a little bit extra help, then yeah, loperamide is something that we commonly use. You have to be careful which formulation of Imodium, because we're very used to, making medicines for kids that have a good flavor, for example. And in so doing, you add sugar, and that can make diarrhea worse, right? So we tend to use the capsules a lot more and have the family mix it a special way. So that will slow down the motility. Works much better if you have a colon, right? It doesn't really work as well in the small bowel, so you have to know the anatomy of the patient. But even upper motility patients, right? We do have patients that, for example, gastroschisis baby that's born with their bowel outside their body. That bowel that was outside the body was pulling on the stomach, right? A lot during utero when they were inside mom. And a lot of those babies will have what we call gastroparesis. The stomach doesn't empty as well, right? So they may be vomiting because they need a little bit of extra help, emptying their stomach. And we will use metoclopramide, which gets a bad name, but we use it frequently. Sometimes even the antibiotics in the right patient, right? Some of the antibiotics you could use a different dose and it just works to speed up the beginning part of the bowel and it doesn't give them more diarrhea. We actually have some babies that are constipated in short bowel syndrome, and sometimes we'll use the antibiotics that give you motility throughout. So again, very important to know what part of the bowel the patient has left and follow the patient's history, know what has worked, what hasn't worked, and it's a lot of trial and error. So that's why the communication is so important. The parent is part of the care. They're here to help you rehabilitate the kid. It's not just the physician or the nurse or the surgeon.
So one of the complications that we've kind of been not alluding yet, but kind of touching marginally, is as part of the overgrowth is this lactic acidosis. Mm-hmm. So the lactic acidosis is when you have this established overgrowth on the bowels of these intestines, and the patient is having a good amount of simple carbohydrates. Mm-hmm. And those carbohydrates, they get fermented for this overgrowth, and it forms a neurotoxin mm-hmm. as part of this fermentation that is called D-lactic acid. Mm-hmm. Get absorbed, and then the patient is a consequence of that. How often your clues or your cues towards thinking about the lactic acidosis is when you have a baby with short bowel with neurologic symptoms, or do you test systematically about this? Or you do labs?
Yeah, we do. It's just sometimes it takes a lot longer to get the result, and you have to go on history. I feel that we see a lot more lactic acidosis in the older kids, right? And maybe it's because the babies sleep more, maybe we don't notice. But it becomes very obvious, especially when you have a child that now you're coming down on formula and really pushing the by-mouth food, especially kids that are going to school during the day and mom is not around and they can sneak in foods that they may not tolerate, right? So I feel like, older toddlers and school-age kids are the ones that we see. And it's pretty obvious, I think, when you see it and it's significant, right? So the baby will get, or the child at this point will get more drowsy. They act like if they're drunk, they're not walking well, like, they've been drinking and they're not balanced. So that's definitely a big problem, which is why I mentioned in the beginning that we have two different dietitians. Everybody has their different strengths, and I have one dietitian that's amazing with TPN and nutrition through the vein, and then I have another one that works a lot with the families with regular diet and teaches the family what's best for this child to eat once they start eating more regular food.
But it makes sense what you're telling us. So you're seeing more of the lactic acidosis once the patient is free to eat whatever he wants.
Correct.
And then he's going to start picking on carbs that he shouldn't be eating, and that's now you are more entered, rehabilitated.
Right.
Using less TPN, and now you're going to be more prone towards falling into this lactic acidosis and the consequence of it.
Yeah, and that's why I think it's so important to teach and educate the families, because I don't want anybody to think that my child with short gut is never going to have a cupcake in their class because it has too much sugar. No, they do. It's just most of the time you're controlling their diet. So like that, the one time that they want to have pizza or they want to have something bad, it's okay. You just know what to look for and then get back on the right track, right? But we try as much as possible to have these kids be normal, or at least have some pieces of normal.
And so moving a little bit towards the surgical aspect of the rehab, and without going into transplantation. Well, actually, there's one more drug that we haven't talked about is GLP-2.
Right.
So most of your patients after a year of age, which is the FDA recommendations, are going straight into a GLP-2, which about that is still TPN depending, or how are you
Not
doing
necessarily. I mean, I think you would be surprised how many patients you can rehabilitate just with diet and time and patience, right? And that's what I tell parents. Every time, again, as I said, it's a relationship. And sometimes you have to go with what a family, if it's safe, may want. Every time I feel that we push the child faster than you should, you end up going backwards. Every time, if I tell you, I think, your child's going to be on TPN 3 years, and at a year you want them off TPN and you're pushing, you start having problems, right? So I think that's the most important. Yes, after a year, you're allowed to use teduglutide. Now, one of the things that you need to remember about teduglutide is it's only been approved for kids since 2019. So we do have 6-year data, but it is 6-year data. It is a hormone, a synthetic hormone. We were part of a study that just closed that was a worldwide registry looking for the side effects and risks of teduglutide. Because if you do some homework, you will realize that in the beginning, there were a lot of concerns about GI cancers because you're basically giving a medicine that's going to make things overgrow. You want the bowel to grow lengthwise or the villi to grow so like that they can absorb more. The villi being, the parts of the intestine that help you absorb. If you give too much, potentially you can form a tumor, right? So thankfully that has not been proven. There's been no reports of that actually happening, but still you have a medicine that's relatively new, right? So although I use it a lot, you want to pick the right patient, right? So who is the right patient? For me, it's always a person that you've tried with diet and they get stuck. And you kind of come to a crossroads, right? So for you to absorb food, you have the 2 walls of the intestine and these little villi fingers that absorb food, right? My personal opinion, if you have a bowel that's very dilated, which a lot of the shortcuts have, if it's too dilated and their villi are here, you can give teduglutide to make the little fingers grow, but you're still going to have a lot of surface area in the middle where the patient's just not going to absorb, right? So is teduglutide really going to help? In a patient like that patient usually has had a lot of line infections because they've had bacterial overgrowth again because you know that they're dilated. Somebody like that, you may go toward a surgical approach more than teduglutide. Now, also, what anatomy do they have? So teduglutide or regular GLP-2 is made in the cecum and in the first part, or the last part of the small bowel and the cecum, the first part of the colon. If you have a patient that has that area, you can give them teduglutide, but they already have their natural teduglutide, right? So you really want to know, is that patient missing that area? And like that, that if you give it, you're going to be helping them the most, right? Because then like that risk versus benefit of being on a drug that we should mention is a shot every single day. Then I think the risks, the benefits outweigh the risk, right? So you really want to see what patient you're using, right? We don't just say, okay, today they turn 1, let's use teduglutide. But it's a wonderful drug. And I think it really has continued to decrease the need for transplant because of it.